So after having discussed about the calcineurin inhibitors, now let me discuss the other group of immunomodulators, that is proliferation signal inhibitors, right? So the next class what we have is proliferation signal inhibitors. So if you take this particular proliferation signal inhibitors, now in this group, like we have the drugs like Sirolimus and as well as Everolimus. First let me tell you the mechanism of this particular proliferation signal inhibitors, and let me tell you what are those drugs in this particular proliferation signal inhibitors. Now we have like various interleukins in our body, but remember, out of which the interleukin 2 is the one which will stimulate the immune system by activation of several T cells, right? So what your interleukin 2 will do is, interleukin 2 will stimulate the immune system. Alright, so now how does it stimulate the immune system? It will stimulate the immune system by activation of several T cells. So by activating several T lymphocytes, right? The T lymphocytes are the one which are involved in the cell mediated immunity. B lymphocytes are the one which are involved in the humoral immunity. Alright, so interleukin 2 will stimulate the immune system by activation of several T cells via activation of mammalian target of rapamycin. So this will, interleukin 2 will stimulate several T cells not directly, via a pathway that is nothing but via activation of mTOR, right? So interleukin 2, it will cause the activation of mTOR. Via the activation of mTOR, it will activate the several T cells. So what does this mTOR stands for? Mammalian target of rapamycin, right? Mammalian target of rapamycin. Now let me tell you what are the drugs in this proliferation signal inhibitors. So if you see the drugs in proliferation signal inhibitors, the drug what we have is the Sirolimus, right? The drug what we have is the Sirolimus. Now in this Sirolimus, which is nothing but your rapamycin, right? Which is nothing but rapamycin. Now what this Sirolimus will do is, this particular Sirolimus, it will bind with the mTOR, right? It will bind with the mTOR and inhibits this particular mTOR. Now you see a point here. Once the Sirolimus binds with mTOR and inhibits the mTOR, now do you think that there will be the action of interleukin 2? No, right? So what the Sirolimus will do is, Sirolimus, it will bind with, right? It will bind with mTOR and thereby it inhibits, right? It inhibits the action of interleukin 2, right? It inhibits the action of interleukin 2 without affecting its transcription. So now once the interleukin 2 is being inhibited, right? Once the interleukin 2 is inhibited, now do you think that there will be activation of immune system? No, there will be no activation of the immune system. So in this way, this particular Sirolimus, it is acting as an immunosuppressive drug, right? It is acting as an immunosuppressive drug and it is also inhibiting the activation of several T cells. Now because this Sirolimus, right? Because this Sirolimus is having an immunosuppressive action, now where is this used? Remember, this particular Sirolimus, it is used as an immunosuppressive agent in organ transplant and as well as the graft versus host disease. Alright, so it is used as, alright, it is used as the immunosuppressive agent in case of the organ transplantation, right? In case of the organ transplantation and as well as, right? And as well as the graft versus host disease. Is that clear? Now, which is the other place where we use this Sirolimus? Remember, Sirolimus is also incorporated in the cardiac stents to decrease the chances of reocclusion, right? To decrease the chances of reocclusion. Okay, so this particular Sirolimus is also present in the or incorporated into the cardiac stents. For which reason? To decrease the reocclusion. Now I'll tell you the mechanism here. See, why is it incorporated into the cardiac stents is because once the stent has been placed into the coronary artery, now the stent is a foreign body to the coronary artery. So the immune system of the individual will try to activate the T cells against that particular stent. Now, in order to prevent the T cell activation against the stent which has been placed in the coronary artery, if you apply the sirolimus to the stent, then there will be immune suppression, and thereby there is no activation of T cells against the stent, and the chances of reocclusion will be reduced, right? Now, what is the major adverse effect of this particular drug, that is sirolimus? Remember, sirolimus will cause the bone marrow suppression. Because it causes bone marrow suppression, thrombocytopenia is one of the major adverse effect, right? So, if you take the adverse effect of this particular sirolimus due to bone marrow suppressive action, this particular sirolimus, it will cause thrombocytopenia, right? Apart from thrombocytopenia, the other important adverse effect is the hyperlipidemia, right? Apart from thrombocytopenia, the other important adverse effect is the hyperlipidemia. Now, remember, sirolimus per se is not nephrotoxic, right? The other important point is this particular sirolimus, it is not a nephrotoxic drug, right? It is not a nephrotoxic drug. Now, but this particular sirolimus, it has a dose dependent action. What is this particular dose dependent adverse effect associated with the sirolimus is the formation of lymphocyte, right? Formation of the lymphocyte. So lymphocyte is increased in a dose dependent fashion by sirolimus. Now, what does this lymphocyte mean is, lymphocyte mean it is the collection of the lymphatic fluid within a body cavity without epithelial lining, right? That is what is called as lymphocyte, right? It is a collection of abnormal collection of the lymphatic fluid within a body cavity without epithelial lining is called as lymphocyte. So let me shortly revise up to here what we have discussed. So what we are discussing is the immunomodulators, that is proliferation signal inhibitors. And in this proliferation signal inhibitors, what we have first tried to discuss is the mechanism of action. Remember, we have the interleukin called as interleukin 2 that will stimulate the immune system via activation of several T cells. And this particular activation of several T cells, it occurs via activation of mTOR, right? Activation of mTOR. Next, now the drugs what we have is the sirolimus. Now what does this sirolimus will do is, remember sirolimus, which is also called rapamycin, it will bind to the mTOR, right? It will bind to the mTOR, and thereby it will inhibit the action of the interleukin 2 without affecting its transcription. In this way, it is acting as an immunosuppressive agent. So where is this used? This is used in case of organ transplantation as well as graft versus host disease. And the other point is, this particular sirolimus is also incorporated in cardiac stents to decrease the chances of reocclusion. And the major adverse effect associated with this sirolimus is the thrombocytopenia due to bone marrow suppression. And the other important adverse effect is the hyperlipidemia. Remember, as such, sirolimus per se is not nephrotoxic. Lymphocyte is another important dose dependent adverse effect by your sirolimus. So what is lymphocyte? It is the abnormal collection of the lymphatic fluid within the body cavity without epithelial lining is called as the lymphocyte. Now, after having discussed about the sirolimus, next let me discuss about the everolimus. Now, if you take this everolimus, remember this is a new drug in this category having a shorter half-life, right? So this is one of the new drug in this particular category, and this everolimus, it has the shorter T-half. And what is the T-half of this particular everolimus is, it is having a T-half of nearly around 43 hours. Whereas for sirolimus, right, if you take the T-half, it is nearly around 60 hours, right? It is nearly around 60 hours. Now, where is this particular everolimus useful? Remember, this particular everolimus, it is useful in case of the cardiac transplantation. Alright, it is useful in case of the cardiac transplantation. And if you take the adverse effect of this particular everolimus, remember, this particular drug Everolimus, these drugs, they increase the risk of hemolytic uremic syndrome, right? They will increase the risk of, okay, so they increase the risk of hemolytic uremic syndrome. Now remember, this Everolimus has recently been approved for the treatment of patients with astrocytoma, right? And what type of astrocytoma is it? It is called as subepithelial giant cell astrocytoma, right? So this Everolimus, recently it has been approved for the treatment of patients with, right, for treatment of patients with 𝐒𝐫. What is 𝐒𝐫? It is nothing but subepithelial, right, subepithelial giant cell astrocytoma, right, subepithelial giant cell astrocytoma. Now which type of astrocytoma is subepithelial giant cell astrocytoma associated with, right, associated with tuberous sclerosis, right, associated with tuberous sclerosis. So this is about your the Everolimus. Now what I'll do is I'll summarize the mechanism of action of your calcineurin inhibitors and as well as the proliferation signal inhibitors. So summarizing the mechanism of action of the calcineurin inhibitors and as well as proliferation signal inhibitors. So we have initially what is called as NFAT phosphate, right? And what does this NFAT stands for? Nuclear factor of activated T cells, right? Nuclear factor of activated T cell phosphate. Initially this is in the inactive form, right? This is in the inactive form. This particular NFAT phosphate is converted into the NFAT, which is nothing but the active form. Now a point what you should remember here is this NFAT phosphate is converted into NFAT in the presence of a substance that is called calcineurin, Now this NFAT, that is nuclear factor of activated T cells, what it will do is, right, it will increase the interleukin 2 transcription. Alright, it will increase the interleukin 2 transcription. By increasing the interleukin 2 transcription, what it will do is it acts on mTOR, right? What it will do is it acts on mTOR, right? That is target of rapamycin. Now once interleukin 2 acts on mTOR, then there will be activation of the immune system. So this is how our immune system gets activated. Now at this point we require calcineurin for the conversion of NFAT phosphate to NFAT. Now if you see the drugs now, at this point of calcineurin, like we have what is called as the calcineurin inhibitors. So what are calcineurin inhibitors? Like cyclosporin and as well as the tacrolimus. Cyclosporin and as well as tacrolimus, they are nothing but the calcineurin inhibitors. Whereas you take the mTOR. Now what are the drugs which will act on mTOR? They are nothing but your proliferation signal inhibitors. So what are your proliferation signal inhibitors? These proliferation signal inhibitors, they include number one Sirolimus and as well as the Everolimus. So Sirolimus and as well as Everolimus, it acts on the mTOR and it will inhibit the mTOR and thereby the immune system doesn't get activated. So this is the mechanism of action of your calcineurin inhibitors and as well as proliferation signal inhibitors.